My name is Erin Davis, and I'm one of the LVAD coordinators at the University of Utah Hospital. And I am here today to present LVAD therapy to you. Luckily, we have two previous LVAD recipients in the audience, so that helps. If you have any questions, I'd like you to, there are parts in the presentation we will pause, and we can answer questions at that time. So, LVAD therapy, it is a surgical option for heart failure. And I want to stress the importance of option, and we'll talk about the different, what you can expect with an LVAD, what's expected of you, and reasons patients go through this. And if you are a previous patient and you've happened to have experienced LVAD therapy, whatever comments and suggestions at the end may be welcome. Just as an overview, heart failure affects 5.7 million Americans every year. Or 5.7 million Americans total. Estimated diagnosis is of over 500,000 every year. A quarter of these patients, patients, are not tolerating their current medical management, meaning they're having to increase their medications. Maybe they're becoming symptomatic with their medications. Maybe they're having to require IV medications and end up in the hospital. These patients that are not tolerating them have a percent survival of 6% at 1 year. It's estimated that 80,000 to 150,000 of these patients need heart transplant. But unfortunately, due to donor limitability, only 2,000 transplants were performed in 2010. So that leaves a big disparity of patients requiring LVAD, or requiring advanced surgical options. Diseases that we're talking about with heart failure include ischemic, people that have had heart attacks, dilated, idiopathic reasons, or valvular, because their valves are bad, restrictive, related to cancer therapy potentially, congenital, viral, so many different reasons for heart failure. A ventricular assist device is a surgical treatment option for these patients with end-stage heart failure symptoms. Since we couldn't find a donor heart, they implanted 13 chipmunk hearts. Unfortunately, this doesn't work. We have to implant a human heart into a human. So supply and demand is definitely an issue, and this is why LVADs were developed. LVAD stands for Left Ventricular Assist Device. It is a machine that's implanted in or next to the heart that assists the left ventricle in pumping the blood to the entire body. So if you remember your heart, you have a right side and a left side. The right side's job is to pump the blood to the lungs, and the left side's job is to pump the blood to the rest of the body. So that's the most crucial part, and when that fails, patients end up in the hospital, can't breathe, all swollen, and eventually die. So why do we do these, put a big machine in somebody? Some of these patients are bridge to recovery. These are temporary patients. These are maybe the very acute, had a heart attack, ended up in the OR, ended up on a device without even knowing it. Hopefully these patients will recover or move on to a more permanent device. We have our bridge to transplant patients, especially for this audience, it's important. These people are listed and waiting. As you know, we showed already, there's only just over 2,000 transplants done in the United States last year. And there are many patients waiting on that list. So if patients start to decompensate and get worse in heart failure symptoms, then they can be eligible for a bridge to transplant LVAD. There are these patients we're not sure. Maybe they might be listed for heart transplant, but they don't meet eligibility. Maybe their kidneys are too bad. Maybe they have some psychosocial issues. Maybe they've had recent cancer. So these patients may get an LVAD as a bridge to eligibility or decision. And finally, there are the patients that don't qualify for transplant, or for some reason after don't want transplant, or it doesn't happen for them, they can have a destination or lifelong therapy LVAD. 3 of the different durable devices, meaning longer-term devices that we use for bridge to transplant for destination therapy, are as follows: the Jarvik 2000, which is on the left, HeartMate 2 LVAD, which is in the middle, and HeartWare LVAD on the right. We'll talk a little bit more about which one's approved, but just so you guys know, all LVADs are required to go through rigorous testing, years and years of testing in many different clinical trials, before the FDA will approve them for use in the United States, and insurances will pay for them. The only current approved device for bridge to transplant and destination therapy is HeartMate 2. Jarvik is in trials for bridge to transplant, and HeartWare is in trials for bridge to transplant and destination therapy. The VAD preoperative workup phase is very similar to transplant, so if you've listened to the transplant overview, you kind of understand what VADs entail. We definitely require an insurance approval and review. And a patient consent. This is very important. We have a very long patient consent now that we expect patients to review with their caregivers. It goes through every expectation they can, that they need to know about the LVAD, what lifestyle changes may require, what risks are involved, and how to contact the VAD team. You'll meet team members during the evaluation process. This includes financial coordinators, VAD coordinators, the cardiothoracic surgeon, cardiologist, social workers, and therapists. We'll do a complete history and physical. That includes lots of heart tests, right and left heart catheterizations, echocardiograms, EKGs, angiograms, anything that we need to do to make sure the rest of your body is in working order. Lung tests include pulmonary function tests and chest x-rays. Exercise tests, we may make you walk for 6 minutes and see how far you go. We may have you get on a bike and breathe into a tube and see how your lungs do. You may have abdominal ultrasounds just to make sure all the kidneys and liver and everything are working. We want to make sure that there's nothing that will cause you a bad surgical outcome if we can try to dot all the I's and cross all the T's. Labs, you'll have lots of labs drawn. It's very similar to heart transplant. These labs measure your chemistry levels, your blood work, your blood counts, your lipids, how much cholesterol, if you're pregnant, if you have prostate cancer. Risk assessment, after we add up all these tests, we put you into a calculator that we have, and it estimates what your outcome will be if everything else goes well in the surgery. Most patients fall in the moderate to low risk. You'll also meet with the palliative care team if you're at the University of Utah, and this team helps advance directive planning and end-of-life issues. So they help really look through and make sure you understand what you're getting into, which we're going to review a little bit more in this presentation. Like I said, some VADs are in clinical trials, meaning not yet approved. We also have clinical trials studying tissues and echoes, and all LVAD patients are offered potential participation in these trials. The coordinator and surgeon will review the trials with you to see if you're eligible. Insurance approval is necessary for trials. You won't be paid for trials, and some extra testing is required, but any extra testing that's over the standard of care is paid for by the study. But all trials are voluntary, so why do patients participate? Because we want to move forward the advance the field of heart failure. We want patients to be able to be part of the research and where the next steps in LVAD therapy land us. I don't know if anybody will be able to see this. We'll show it on the slides in a second, but when we started a few years back, even 10 years ago, this was the standard of care, the HeartMate XV, a big, huge 5-pound machine that was implanted. And because of trials, because of patients that were willing to participate in trials, LVADs have become smaller, like the HeartMate 2 and even the HeartWare and Jarvik. So how do you know if you are an LVAD candidate? First of all, we want to make sure you have an anticipated survival benefit. We don't do surgery on patients we don't think are going to live, that it's not going to help. You're in class 3 or 4 heart failure. Now that classification, 1 through 4, has different levels. Class 3 and 4 are patients that can either barely do their activities of daily life. You get up, you shower, you eat, you have to go take a nap or sit down. You maybe walk to the mailbox, you have to come back and sit down and rest. Those are class 3 and 4 heart failure patients. They're very, very limited. You have a VO2 test of less than 14. This is the getting on the bike, breathing in the tube, and seeing how well you do, how well your oxygen is taken up by your body. You need, if you have any need for IV inotropes, these are milrinone drobutamine. If you have a PICC line, you have to go home on an IV medicine to help support your heart. That outcome of that medicine is usually not very good, and these patients may benefit from LVAD therapy. If you are being rehospitalized even more than once a year for heart failure exacerbations, meaning fluid overload, you have to come in and get IV diuretics, you have to be in the hospital, you have to be in the unit. These are things we want to know about. We don't want you in the hospital, we want you out living life. These are patients that may benefit from LVAD. And patients not tolerating their heart failure medicines. They can't increase their blood pressure medicine because they keep bottoming out, but their heart is really weak. So these are patients we may look at as well. If you have any of these risk factors, LVAD may not be a good option for you or may increase your chances of bad things happening. Patients that have current infection, a previous stroke, patients that are non-compliant and have a history of non-compliance, any other organ disease, kidney failure, liver failure, skin cancer that may decrease your life expectancy. If you have right-sided heart failure, we can't fix that with the left ventricular assist device. You would need something else, like a total artificial heart or a biventricular implant. But since we're talking about LVAD today, that is definitely a risk factor. We won't put an LVAD in somebody that has right heart failure. If you're older than 80, it can increase your problems. If you're obese, with a BMI greater than 40, or if you're very, very cachexic or malnourished with a BMI less than 18, these are increased risks of death and bad things happening. If you have diseases that impair effective rehabilitation, things like multiple sclerosis, muscular dystrophy, that may make you a higher risk candidate. If you have any active substance abuse, that definitely makes you higher risk. Alzheimer's, dementia, because we definitely need you to know how to take care of your LVADs, that may make you a higher risk. If you don't have funding, if you're not insured, that we don't want to devastate you financially and put you on the street by doing a big expensive surgery. And if you don't have a caregiver, you may have an increased risk of having an LVAD. That being said, we do implant patients that don't necessarily have caregivers, but they do understand that they have a higher risk associated with not having somebody there to help them. After you receive an LVAD, or if you're just living with heart failure, or if you have any type of surgery, these are some of the problems that can come up. And these are the risks, and I won't go into too much detail here, but pretty much anything bad that can happen due to surgery or due to LVAD. Specifically, our top 3 risks after LVAD are stroke, infection, and bleeding. You are required to take anticoagulants or blood thinning medicines, so to prevent stroke, but they can also lead to bleeding, so there's a very fine line that we monitor you closely. And then we'll talk a little bit more about infection in a minute. Very important to know is to be mentally prepared and ready for LVAD. You need to be involved with your care. You need to be able to voice your opinions. You cannot just rely on other people to do things for you. Otherwise, you don't do well. You need to be teachable. You need to have a positive social support network. Even if you don't have a direct one-on-one caregiver, you need to have people you can call, people you can be around to help you if needs be. Sorry about that. You need to be compliant and follow up. You need to commit to live life. We don't give patients LVADs who don't really want to be alive. It's not a good idea. They don't do well. You have the final say. After everything we present to patients and after everything we, all the workup, it doesn't hurt our feelings if you say this is not right for me. You consider your options carefully. You need to make the decisions with support of your family and friends if you can. It doesn't help to try to put your LVAD together by yourself. You can't save any money by going on the black market and buying, for example, Craig's old LVAD that he thinks he would put on eBay. I want to talk a little bit about the surgery next. It is an open heart surgery. It can last anywhere from 4 to 8 hours. I have seen them last over 24 hours, so it just depends on what we find when we get in there. But on average, it's 4 to 8 hours. You're on a heart-lung machine, and your incision is usually down the middle of your chest. There is sometimes a device we can put in through the ribs, but most patients have an open heart middle of the chest incision. The LVAD is placed in or below your heart, and there's a flexible tube attached to the aorta, or the big blood vessel that carries blood from your heart to the rest of your body. There's a drive line or power cord that's tunneled under the skin and exits the belly. This connects the LVAD to external power and to a controller that monitors and tells the pump what to do. And the LVAD, the actual pump inside you, continuously sucks blood from your heart and propels it to your body up to 10 liters a minute continuously. As I just mentioned, this is a very invasive surgery. So I will show you some pictures. If you're queasy, you can look away, but these are pictures of implanting an LVAD. So what you see here is the pictures taken at the head of the bed. So the patient's head is at the bottom. The surgeon and the assistants are surrounding. We have now opened the chest from just under the neck down to just above the navel, or just below the rib cage. And they're trying to dissect out the heart so they can get to the heart from all the other organs. The heart's still pumping. The tubes that you see in there are carrying blood from the heart to the heart-lung machine so that we can work on the heart. And what you see there is we've poured a hole in the bottom of the heart, bottom of the left ventricle, and inserted a plastic-looking tube to hold it open. That is where the inflow of the LVAD is actually going to be placed. It's going to be attached to that with very strong zip ties and lots of sutures. There you can see the LVADs in place. The heart's kind of tucked under the left side there, and there's a long white tube that comes up the center. That's the return cannula that carries the blood from the heart to the aorta and the rest of your body. The big metal clamps on either side are what separates your sternum and your breastbone so we can get in and work on it. Once we're in surgery, we turn the LVAD on. These are the readings we see. We immediately get some flow. We set the speed. The LVAD coordinator is in the operating room messing around with this machine, making sure we get the right speeds and settings for you. And then we take you off the heart-lung machine and the LVAD takes over. After we assure that all the bleeding and all the sutures are in the right spot, we go ahead and close the chest. What they're doing there is they're just rinsing out everything, sucking all the fluid, blood out, and wiring the chest closed. There'll be sternal wires that suture together, and then the skin's brought together at the end. That's the LVAD surgery. So you have an LVAD, and now what? Here he says, let's run through the basic operation of your new artificial heart. When you wake up and you're ready to get out of bed, shift into first gear. I wish it was that easy, but it isn't much more complicated than that. Some physical changes you immediately notice with an LVAD. First of all, this is where I'm going to show you the old versus new. Your heart pumps every minute, continuously, pumping blood to your entire body. It's a big pulsatile device in your chest. So, back when the LVADs were created in the 90s, they created big old pulsatile devices that acted like the heart. This was called the HeartMate XVE. It was weighed, like I said, well, it was about 2.5 pounds, feels like 5 pounds. Attached to the bottom of the heart, carrying blood to the aorta, there was valves inside, and it pumped, displaced air and blood to pump blood through your entire body, just like your heart would. The problem was it was heavy, it was noisy, and it wore out within 18 months to 2 years. So that wasn't a very good long-term solution. If the patient didn't get their transplant within that time, or if they wanted to live the rest of their life with it, it wasn't a good option. So in order to create something smaller, they had to create something that was continuously flowing. There was no way to make a pumping function anymore. So they created, for example, the HeartMate 2. It's non-pulsatile. It has a continuous impeller that spins anywhere from 9,000 to 12,000 revolutions a minute, sucking blood from the left side of the heart and spinning it to the rest of the body. It's quiet. You don't hear it. It's smaller. It's lighter. And it means that you may or may not have a pulse after receiving it. So you'll have a continuous blood pressure because there's continuous blood going, but it won't be a systolic, diastolic pulse. As we said, there's a drive line that exits that body that has to be connected to power. There's no such thing as a fully implantable device yet. So the brains of the system is the controller. It delivers power and operates the pump. It displays visual and audible alarms, and some even, like the HeartMate or heart wearer at the bottom there, may display flow readings as well, so everybody can see what their flows are. The batteries, everybody has to be plugged either into the wall and through AC power or batteries. There are lithium-ion rechargeable batteries. Depending on the device you receive, they last from 4 to 12 hours. For example, the Jarvik is 8 to 12 hours on one battery. HeartMate 2 is 8 to 12 hours on 2 batteries. HeartWear is 4 to 6 hours per battery. And of course, then there's battery charger that they all plug into at night. If they run on AC, there's also some type of monitor or plug that will connect them to the AC power. HeartMate 2, for example, has a big power module. It's 10.5 pounds that plugs into the wall. HeartWear just has a power cord like a laptop cord. And Jarvik never runs on AC power, it only runs on battery. Fortunately, you don't have to carry jumper cables to restart your LVAD or pacemaker. But there are some emergency things that we do need to review that you must carry with you in case of emergency. All LVAD patients have a bag with backup equipment. This bag will contain an extra controller, extra batteries, and extra cables if needed. The bag should accompany the patient at all times. The patient also has a LVAD book. This has all your vital information in it. Take this with you to clinic and any hospital admission. This is what's going to help the doctors know what's going on with you. It keeps not only your history in there, but it also tells them how to get a hold of us. We also now have all patients have emergency bracelets to wear. For example, on this one you see LVAD patient, University of Utah, 24-hour on-call VAD coordinator, and how to get a hold of us. On the back of it, it will tell exactly what pump they have and what to do. HeartMate 2 LVAD may or may not have a pulse. Is the pump running? Hum equals yes. Check power connection. Defibrillation okay, call for CPR. So this lets anybody that responds to you, if you went down at the store or at your house and the EMS responded, it helps them know what to do. So if you came across somebody that was unresponsive with an LVAD, or you or yourself are, the first thing is to find out, is the patient responsive or unresponsive if there's alarms going on? Is the LVAD pump running? Listening over the patient's heart with a stethoscope, is there a hum? If you don't have a stethoscope and you just lay your head on the patient's chest, you will hear the pump whether it's humming or not humming. If the pump's humming, it's running. If it's not humming, it's not running. The most important thing is to get the LVAD running. Find out why it stopped. Is that something become disconnected? Reconnect all the connections, change the batteries, change the controller. Of course, contact the LVAD coordinator immediately. If you can't get the pump running, then CPR can be done, chest compressions can be done. If it's not running, it cannot be started. We want to try to make that kind of a last option, because if we start pounding on somebody's chest and we have this big metal piece in the heart, we don't know what damage we may do. Defibrillation and shocking, so anybody with an internal defibrillator, or if they come to you with paddles and you have a bad rhythm, that can be done without hurting the LVAD. Again, anytime there's an emergency, the LVAD coordinator on call should always be contacted. So you have this LVAD. We've kind of gone through equipment and what it looks like and what it is and how you get it. Is there any questions right now on what we've covered?
Well, I have one question. You said statistically there's about 100 to 150,000 people. Is that just the heart, or is that other organs too?
Just heart. Yeah, we're just focusing on heart. We haven't even touched on liver, lung, kidney, any other transplants. So just heart transplants. It is estimated that 80,000 to 150,000 patients in the country would benefit from heart transplant. Now, not all those qualify for heart transplant, but those are the patients that would benefit from it. So, any other questions? Okay. What we're going to review now is kind of the typical post-operative course. You have an LVAD, now what do you need to expect? First of all, as soon as after surgery, you're going to be taken to the intensive care unit. You will be sedated. You will have a ventilator breathing for you. You'll have central lines or IVs in the neck. You'll have chest tubes and drains and catheters, and you'll look pretty much like an alien going into the unit. You won't remember it, which is good. Your family members will. But in this ICU is where we watch you very closely. We want to make sure there's no bleeding. We want to make sure we're not going to have to go back in and do any reoperation. We want to make sure the LVAD's running well for you and that all your organs work. So you're peeing, you're making blood cells, you're mentating, you can respond to commands. Our immediate goal after, within hopefully 12 to 24 hours, is to get you extubated, get that breathing tube out of your mouth. We do this when you are able to be woken up from sedation. You can follow commands, squeeze my hands, shake your head, lift your head, and that you're stable. We're not planning on going back to the operating room. After you're extubated, there is a lot of deep breathing, coughing, and respiratory treatments that go along with that. And although you've just had your heart and chest opened up, it may hurt to cough, it may hurt to deep breathe, but it's extremely important to prevent pneumonia. You'll receive some antibiotics, because we, of course, dug around in your chest, and you'll start your anticoagulation so we don't have any clots form in your pump. As soon as you're extubated and able to sit at the side of the bed, you're going to start physical therapy, occupational therapy, and cardiac rehab. This is the painful, long process of getting you back on your feet. You spend about a week or so if everything goes well in the ICU. If you have little hiccups here and there, you may stay longer. You'll eventually go to the cardiovascular medical unit, CVMU, here at the hospital. Over at the VA hospital, you'll go from our ICU to their ICU and then to 3 West, which is where we take care of the patients over there. You will still probably have a couple chest tubes draining blood out of the area we worked on. You'll have a couple drains, and all your IVs and stuff and chest tubes will be removed as soon as possible. We want you to continue with your aggressive respiratory treatments. You'll use the incentive spirometer, that stupid little breathing apparatus after surgery. You'll wean off the oxygen. We try to get you off the oxygen. Oxygen is a crutch that we want you off if at possible, as well as it can cause nosebleeds from the dry air blowing in your nose. So we try to get those off. We continue aggressive therapies, PT, occupational, cardiac rehab, walking at least 4 times a day, if not more, and basically being out of bed most of the day. And this is hard. This is a hard thing to ask. It seems easy when you're not patient, but it's definitely hard. You'll definitely start some LVAD education. If you haven't already in the ICU, you will on the step-down unit, the CVMU or 3 West, and we'll talk a little bit more what that entails. If you qualify and you've spent about a week or so on the CVMU and stabilized, we'll transition you into inpatient medical rehab. This requires an actual physical transfer at the University Hospital to another floor, and at the VA you'll be admitted into their rehab program. This is based on how deconditioned you were ahead of the surgery and how you qualify physically and financially. It entails 3+ hours a day of intense physical, occupational, speech, recreational therapy, and everything else we can do to you to get you back and moving. You'll continue your LVAD education, and we'll transition you to home life with your LVAD. Fortunately, we can't mandate that you cycle on a bike every hour to recharge your LVAD batteries. That doesn't work. But it is very important that you stay active and not lay in bed. And during the LVAD education, when you're getting it at the end of the ICU stay, beginning of CVMU stay, or into the inpatient rehab stay, you need to become an expert of your device. You need to be familiar with all your components. I want you to know the names, because if you call me on the phone and you say the black thing connected to the white thing is beeping and the gray thing looks like it's broken, I don't know what you're talking about. You need to know the names of your equipment. You need to be able to correctly connect and disconnect all your power connections so that you are capable of doing this in an emergency as well as every single day. You need to be able to properly care for your equipment. We don't throw our equipment, drop it, keep it in the sun, put it in the freezer, all those things. You need to be able to identify alarm situations. What does this alarm mean and what should I do? And then, of course, we're going to teach you and or your caregiver how to take care of your drive line. This is the power cord that's exiting your body. This is where the source of infection happens. Patients with LVADs are not immunosuppressed. They're not like transplant patients on medications that make your immune system low. But you do have a power cord or exiting your body that directly connects your heart to the external air. So we can teach you exactly what to do to keep this sterile and secure and infection-free. If you follow these directions very carefully and take care of this drive line as if it's your lifeline, because it is, you should not have any infection. You'll complete a hands-on and written test. You'll know how and when to call the LVAD coordinator. We actually have you practice a page to us. And know that you will not be discharged home until you're completely able to take care of yourself and your LVAD independently. It's very important to know how to contact us. We have 3 different ways, or actually technically 2 different ways, 3 different pathways. Daytime, if you have a question like you need a med refill or you had a question when your next appointment was, that was when you call the office phone. And that's answered every day, Monday through Friday, 8 to 4. If there's an urgent issue or it's a weekend and there's an issue, comes up, but it's not the emergency, you need to have us paged. So this is pretty much every other issue that falls in, you need to go hold an LVAD coordinator falls into here. The only difference is when an emergency issue, so if you are going down, you do not feel well, you feel like you're going to pass out or you have passed out, this is when you're instructing your caregiver and or anybody around you to call 911 first and then us. You need to have us on the phone when the paramedics arrive because they may or may not have had experience with your LVAD. So page 911 first and then us. So you're getting out of the hospital. First of all, you need to temporarily relocate to Salt Lake City area. This 1 to 3 months after discharge is if you are not currently listed for transplant. If you're currently listed for transplant, you fall into a totally different category and another different presentation, which requires much longer relocation. But let's say you're not actively listed for transplant. You're on hold right now, status 7, or you're waiting to become eligible for transplant. You may go home after discharge, usually between 1 and 3 months. This allows us time to keep you close to us and make sure you're stable You're not going to come back to the hospital for your admissions. You're not going to have problems with your equipment. And then you're able to go back to your home, wherever that is, whether that's Salt Lake, Montana, Nevada, Alberta, wherever. Social workers can help you coordinate housing. That's an issue. Know that you're going to have clinic visits up at the hospital 1 to 2 times a week for the first week, and then probably weekly until you're ready to go. But you do need to go at least 2 weeks, no drama, stay in Salt Lake. This is kind of Dr. Selzman's little catchphrase, no drama. This means not coming into the emergency room, not having to come to clinic every day, being able to care for yourself and, not sending emergency pages to the coordinator every night, things like that. If you're having those issues, we want you to contact us, but it means you may stay a little longer in Salt Lake because we want to make sure you're not going to have to do that when you go back to your hometown. When you are ready to go back to your hometown, wherever that is, the VAD coordinator will travel to your hometown and do community training with the emergency room there, the primary doctor there, cardiologist, EMS, fire department, and anybody else we get our hands on. We want everybody in your home area to be familiar with you to help you if you have problems. You will have, once you do return to your hometown, you'll have an immediate visit with your local cardiologist or primary physician. You will be followed by your local cardiologist or primary physician as they see fit. This usually is monthly for 3 to 6 months. And then it may be every 3 months, maybe every 6 months, just depends on how well you do. You will probably need to return to Salt Lake to follow up with our team as needed. So if there's a major emergency that your local people can't handle, or usually every 3 to 6 months. It's usually every 3 months for those getting ready for transplant, and every 6 months for those who are lifelong destination therapy. So hopefully your trips to Salt Lake are minimized. You will receive phone calls from the VAD coordinator, usually at least once a week to monthly, depending on how you're doing, just to check in. It is really, really important when you're discharged and during your follow-up to know why you're taking medications and which ones you're taking. If you don't take them correctly, you can die, you can have strokes, you can end up in a very bad situation. So hopefully your mother or your wife or your friend does not have to blow gun dark moving with your medicines. You need to take responsibility to order your dressing supplies and your medications when you're low. Don't wait till you're out. You always need to notify the coordinator before stopping and starting medication. So if you decide you're going to start this new herbal supplement, you need to call us. If you're going to decide you don't want to take Coumadin anymore, please call us first. Because we are going to review with you what bad things can happen. All LVADs do require blood thinners. This is usually standard aspirin and Coumadin. This does make you a little high risk for bleeding, but hopefully we have a goal that's not too outrageous and that we can control any bleeding issues. If you have histories of strokes in the past, histories of clots in the past, we may increase your medicines or your dosages or add additional medicines on. They're always patient and device specific. To prevent strokes, please take your Coumadin faithfully and follow up with your INR checks. You should never go more than 2 weeks without checking your INR. It's important for LVAD patients to keep daily records. This includes just glancing at your readings and writing them down, weighing yourself every day, checking your temperature, and your blood pressure if you're able. This will help us manage you at home and keep you at home so you don't have to come back to the hospital for bad things. And when things do happen and you don't feel good one day, we can go back and review what you have been, and if anything's changed, we can decide if the reason why you're not feeling good is because you're just not feeling good, or if it's something wrong with your LVAD. You will participate in both inpatient and outpatient cardiac rehab and exercise programs. This does not end when you discharge. You will continue to be in some type of exercise program. Patients that don't follow this recommendation do not do very well for very long. You cannot be sedentary. You do need to maintain phone and electricity services. You need to be able to power this device, and you'll be able to get a hold of us and us get a hold of you. Please notify the VAD coordinator anytime you're traveling. We have over 100 centers across the country that have LVAD patients at different hospitals. So if you go to some location, Seattle for example, we want to let them know if something happens that you're out there and that you will come to their hospital. We also want to tell you what to do with your equipment, how to get it on the airplane, how to unplug it, how to change the battery, and all the different maintenance that may take to travel with your equipment. Like I said, there's no fully implantable LVAD system. There's always an LVAD with a drive line. So it has to come out of the belly somewhere. Driveline must be covered with a sterile dressing. As you can see on the top there, that's a beautiful exit site. There's no infection, there's no redness, there's no open area, there's no drainage. That's what everybody should look like by about month 3 to 4 after having the LVAD placed. And it stays that way because in the bottom picture you can see it's dressed and covered and secured very well. So it will not get pulled out and will not be infected. We prevent it from getting pulled by securing it not only with the white knee fix tape, but with either a clear tegaderm, an abdominal binder, and a centurion anchor, which is another patch to hold that line in place. The sterile LVAD driveline exit site dressing change prevents infection, stroke, pump exchange, and death. It's a very serious thing that it is easily prevented. Hand washing is very important. Keeping sterile during the dressing change with a mask and gloves. Making sure it's clean, dry, and secure. And reporting to us any changes immediately if you notice something. Don't think we're just going to get mad at you and yell at you, and so you just don't want to tell us about bad infection you think you might have. Here's some good pictures that we use for references to patients. To the left, you can see that's beautiful. That's what we want it to look like. If it starts looking like number 2, you want to call for sure. If it looks like number 3 or 4, you may be in a lot more serious trouble requiring admission to hospital, IV antibiotics, and even pump change out. So the major problem with infection is infection can equal stroke. When you get infected, you become easily clottable in your blood. And those can be able to not only clotting off your device, but also sending a stroke. That can be very devastating.
And that can be caused by being unsterile, right? Not being sterile.
Yes. So his question was, how do you cause infection? And it can be because you're not sterile with your dressing change. It can be because you drop your controller and your spline wasn't secure. It's because you just were being lazy about doing the dressing change, or you got it wet and didn't dry it off. There's many different things that can cause those things. But if you follow the steps of securing, keeping it dry, and keeping it sterile, you should not have an infection. There are some lifestyle changes that go along with LVAD. I like this slide because I wish I could do this with all my patients. To help patients realize that they need to make immediate lifestyle changes, Dr. Franck has their clothes with 1 foot in the mouth grid. So it's very important that you want to live. If you want to live life, there are some things you have to do. You cannot do poor health maintenance, poor health care if you want to live a nice, long, healthy life. And the purpose of LVAD therapy is to do that. We want to improve your functionality, quality, and longevity of life. So far, the newest device, HeartMate 2, has been out on the market for 7 years. So the longest patient on support and has lived successfully is 7 years. And we hope that continues many, many years. There's never been a pump just stops and fails. That doesn't happen anymore. It used to with the old ones, it doesn't with the new ones. So it's very important that you follow some of these next steps and you can live a long, healthy life with an LVAD. Living with the LVAD is an adjustment. Many of my patients have told me it takes between 1 and 3 months to even feel like yourself again. How about, I'm going to ask briefly our 2 previous LVAD patients, how long did it help before you felt like yourself again after LVAD?
I say about 4 months.
4 months?
I was feeling real good after about a month and a half.
Month and a half.
Okay.
So again, ranges anywhere, depends on how debilitated you were prior, depends on how well your surgery and care went during the hospital, and how well you've been taking care of yourself after. So there's many factors. But again, you can get to feeling back like yourself again. It does require exercising, eating right, being active. This helps you with the mental adjustment of the fact that you're plugged into something and living on an LVAD. It's very important with an LVAD to stay hydrated and report any illness right away to the VAD coordinator. That's why we're on call 24 hours a day, 365 days a year. It's extremely important to identify a strong support system. A caregiver can help you not only with transportation, because initially you won't be able to drive until approved by the surgeon, usually 6 to 8 weeks, so that helps you have somebody that can help you out with the driving places. They can also help you with equipment, medications, and emergencies. It's nice to have an extra set of ears around in case you go down. There is an increased risk for LVAD patients who do not have a caregiver identified. We still will give patients LVADs who don't have caregivers, but knowing if for some reason they go down and it was something like an alarm that could have prevented and they don't have anybody around them, then there's no one to help them out. And we have had some deaths happen that way, where we think they probably could have been prevented. No one is a rock, no one is an island, like that song says. You must have help in your life and support in your life somewhere. All heart failure patients suffer from depression at varying degrees. That's just a fact of life. So know that depression and anxiety can be treated, and we want you to discuss this with your VAD team right away. You are not weak because you're depressed. You are not weak because you're anxious. It's just part of living with an LVAD. So if we can help you with either medications or support groups, we will to help you fight any depression and anxiety. There are different support groups. The University of Utah and VA patients have not only this transplant group that meets, but also a bi-monthly VAD group now that meets. There's a national group at www.mylvad.com and Facebook groups, including From the Bottom of My LVAD Heart and the VAD support group. So those are also options for patients, either when you're thinking of LVAD therapy or after you have an LVAD. End-of-life care is real. When I first started this job and I saw the bad things that happen, some patients die. It's just part of life, no matter what we do for them. And when I realized that my goal as an LVAD coordinator was to help patients live a very happy life until they die, whether that be in 6 months or 6 years, that was my goal. The palliative care team and the social worker can also help you express your wishes via an advanced directive form. It's really nice to have filled out. Know ahead of time what you want done if this happens. You have steps for the team to follow. That way you're not left in the hands of whatever physician's on. You're not left in the hands of your caregiver who's already distraught enough. If you already have it written out, it's much easier to make any decisions if bad things happen. Identify somebody that can be your medical power of attorney. It doesn't have to be a spouse. It could be a friend. It could be anybody. But if you have it identified and written down, not just vocalized, that helps. In the event of adverse events, so you have maybe a big stroke or something happens and you end up with a very poor quality of life, you do have the right to have your LVAD turned off. That always is within your right to do. And we will help walk the appropriate steps and get the appropriate people involved. It's not a painful process. It can be very relieving to families. That's where we end up. But since we're talking lifestyle changes and hopefully a positive outcome with LVADs, LVAD patients can do everything everybody else can do, except for falling. LVAD patients cannot play contact sports that may traumatize the driveline and equipment, but any other sports fine. And unfortunately, LVAD patients cannot swim or go underwater. This driveline exits the body in the belly. There have been some cases of patients that we have received them in the back of the skull. We've done one, actually the only patient in the country at this hospital, so that he could swim. It did take a lot of FDA approval to obtain that, and hopefully that's where we're going in the future. Either the LVADs will be all internal, you don't have to have any extra cords, or maybe we can do more skull implants so patients can swim. But for now, no swimming or submerging. Patients can shower, but just not go underwater. But patients can travel, fly, camp, fish, hunt, hike, walk your dog, play sports, work, garden, shop, go out to eat, have sex, play with pets, children, and grandchildren. Basically, we want you to live life. I always feel very sad when LVAD patients say I'm limited because it's LVAD, because it should not limit you. And if it does limit you, then we need to do something to help you get back to life. LVADs not only delay death. Try to stop the Grim Reaper when it wants to come. But VADs should be an alternative to life, not just. It should not just be an alternative to death, but rather a bridge to life. We want you guys to live life. And there's our team. If there's any questions, I'll go ahead and take them.
I have one. Well, different institutions require site changes on LVADs. I just found out that VA and the university requires site change every day. Now, in a mountain medical center requires it twice a week. So how is?
Okay, I'll address that. I'm sorry I didn't bring that one up. So his question was, how come different institutions, LVAD institutions across the country, require different requirements for LVAD dressing changes? Some are weekly, some are twice a week, some are daily. We just participated in a national study with Intermountain and many other, I want to say 120 sites around the country on what people do with LVAD dressings. Every single center does something different. overall, from our paper, we found out that the infection rates are pretty much the same. The reason we actually have 2 dressing changes at the university now, we have daily and we have twice a week like Intermountain. The problem with the twice a week is you have to have a special kit to do the dressing, whereas the daily is gauze, saline, soap, and tape. It's very cheap and easy to come by. The twice a week dressing, which is great because we use it as well, requires a very special foam tegaderm and very different dressing ability. It's a little more complicated, so patients that can handle a little more complicated, we do allow them to go to that. The last most important thing with the dressing change, though, is if you want to shower daily, you must change your dressing daily. If you are okay showering twice a week, we will transition you to a twice a week dressing. But if you are one that likes to wash your body every day in the shower, and not just spit bath it in the sink, you cannot do the twice a week dressing. It has to be changed. That's the catch with the twice a week dressing. There are other centers that are exploring options of not doing a dressing. So far, those have not been good because most of those centers have high infection rates. But we're just not, there's just no set standard at this time. But again, our thought process and what makes sense with our infectious disease group, with our experience, is that if you keep it dry, secure, and clean, you're not going to have infection. If you can do that with a twice a week dressing, great. But if you're like I said, you're showering every day, that doesn't work. Does that answer the question?
Thank you very much.
Any other questions about lifestyles with the LVAD? Why you give an LVAD?